Great. Okay. Excellent. So thank you very much for joining us today for our next PCFA consumer webinar surrounding the topic of erectile dysfunction and prostate cancer treatment. And we're very lucky today to have Dr. Gregory Malone, who works out of Brisbane Urology Clinic here in Brisbane. He's a urological surgeon that has a keen interest in looking after men with prostate cancer, both from a treatment and survivorship point of view. So I'd like to hand over to Greg today to give us a talk about erectile dysfunction.
Thank you so much, Chris, and thank you to the viewership who are there, and I hope that you all find this of value. So as Chris alluded to, I'm a urological surgeon. My major interests are robotic surgery and reconstruction, and that in men, and that includes the management of erectile dysfunction and also urinary incontinence after surgery. One of the websites that we've developed have tended to be less proactive with respect to their health, but what we want to do is have men really focus on what, as urological surgeons, we feel are the important bits and the important end of the anatomy. This talk aims to discuss a few aspects of erectile dysfunction. Firstly, I'd like to define what is erectile dysfunction. I'd like to discuss the most common causes for erectile dysfunction, outline a practical evaluation of men, review the treatment options with you, and then provide suggestions as to who should go and see their urologist. As you've probably seen previously, erectile dysfunction is the inability, to achieve or maintain an erection adequate for intercourse. And this is to the mutual satisfaction of the man and his partner. So just to remember that both partners in a relationship are affected by erectile dysfunction, and that's a critical aspect of managing it in my setting, in my mind. Erectile dysfunction essentially is a disease of aging. As you can see from this slide, young men uncommonly have erectile dysfunction, but sadly some young men do. As a man ages, their risk of erectile dysfunction will increase, proportionate with their age and also with their obtaining comorbidities such as previous surgery, diabetes, hypertension, vascular disease, and the effects of aging, and also those lifestyle factors such as smoking. So how do we get an erection as a man? Well, essentially, the brain controls sexual function. It controls the arousal response, and it initiates the psychological, neural, and blood vessel changes that produce an erection. The hormone, the male hormone testosterone, really controls libido. In terms of the physiology of this, the nerves from the brain relay the signals of arousal and sensation to and from the penis. And the arteries then are dilated by those blood vessels into the penis, and that causes the erection to occur. So there's filling due to inflow of blood as a consequence of direct stimulation from the nerves. To prevent that blood just washing straight back out, the filling of the penis results in compression of the veins, and this basically holds blood in the penis while there's inflow. After intercourse or after orgasm, the arterial inflow diminishes, the veins open up, and the penis detumesces, or there's the loss of erection. If, as you can imagine, if the arterial inflow is not sufficient, then that can be a factor which results in ongoing leakage, which is one physiological cause for erectile dysfunction. So therefore, erections are a coordinated interaction of multiple organ systems. It's a psychological, endocrine, or hormonal, vascular, and nerve system function or event. And so there's lots of parameters or steps in that pathway that can be impacted upon that can produce erectile dysfunction. So therefore you can see from this, it's not quite as simple as you would think. A lot of men feel that erectile dysfunction must have a simple origin, but in some cases it can be quite complex. And therefore we do look at each of those factors in turn. So psychological causes such as anxiety, depression, fatigue, guilt, stress, other factors such as marital discord or discord in the relationship, and obviously other psychological factors such as alcohol consumption can all contribute to erectile dysfunction. In terms of non-psychological or organic causes, because that's how, as a surgeon or a physician, we tend to approach this. Is it a psychological cause? Is it a physical cause or an organic cause? Or potentially is it a combination of both? We do know that cardiovascular disease is one of the most common risk factors for erectile dysfunction. And obviously there can be many factors which precipitate that risk of cardiovascular disease, such as family history, high lipid profile, smoking, obesity. So cardiovascular disease, hypertension, and diabetes are significant contributors to risk. And then we look down the list of factors which can contribute to erectile dysfunction, such as lipid disorders or cholesterol issues, previous pelvic surgery or radiation, neurological causes such as low back pathology, multiple sclerosis, etc., and central nervous system disease, issues after priapism or a prolonged erection from using injections. Hormonal deficiencies can contribute, such as an absence of testosterone or other hormones such as thyroid dysfunction, chronic illnesses such as renal failure, and obviously, as mentioned, substance abuse can be a contributor as well. Some patients are actually develop erectile dysfunction as a consequence of treatments that they've been initiated on by their doctors, and some of these can be such medications as blood pressure medicines, antidepressants, H1 and H2 receptor blockers for reflux, although that's not common, anticholinergics, and hormone therapies. And some of those hormone therapies are used to actually treat issues such as prostate cancer. So LHRH agonists, which we use commonly for prostate cancer treatments such as Lucrin, Zoladex, Eligard, etc., which are used to treat prostate cancer, can obviously cause a reduction in testosterone and erectile dysfunction. So how do I evaluate a patient? Well, I take a general medical history looking for any of those risk factors and considering factors such as smoking history, alcohol, substance abuse, medications, and then we move on to cardiovascular history to ascertain is the patient fit or is there a cardiovascular risk profile. And it's very important to note that when that there is a high association with cardiovascular disease and erectile dysfunction. And in the UK, when I was a fellow back in 2002, we used to run concurrent clinics where patients who had erectile dysfunction, if they were younger, would be referred over to the cardiac service to assess them and make sure there's no underlying cardiovascular disease, because erectile dysfunction in younger people can be a sign of vascular disease. Also take an endocrine history asking about libido, and then we do what's called a SHIN score, and this is a score essentially where a patient, which is self-administered, the patient's handed the note and they fill out this form and determine, based on this score, whether they have severe erectile dysfunction, moderate, mild to moderate, or mild erectile dysfunction. And it's a good way of quantifying the issue numerically. So in terms of the physical examination, when I examine a patient for erectile dysfunction, I'll watch them walk into the room, look if there's any obvious neurological issues, Parkinson's disease. I'll examine the patient, looking at the genitalia, ascertaining if there are physical issues or signs of disease such as Peyronie's disease or penile scarring. I look at the testicular volume to make sure that they should have a testosterone level that would be normal. And I do examine their prostate to make sure that there's no other issues from a urological viewpoint. And then we do some routine blood tests, checking the lipids, normal blood tests, renal function, thyroid function, testosterone. And in some circumstances, I may elect to get a PSA just as a part of a complete neurological assessment. What I want to know really is how rapid has this event come on? Because the rapidity of onset of erectile dysfunction is important. If it's a slow progressive onset, then that does suggest organic disease. If it's a rapid onset, then that can highlight that there may be a psychological component to this. And obviously, I want to know if the patient has any past surgical history, such as having had radiation therapy for prostate cancer or a radical prostatectomy for prostate cancer, or some other pelvic surgery such as low bowel cancer resections or bladder cancer resections. I ask about the relationship with the partner. I like to know other factors such as the aims of the couple, if the couple are present at the same time. And what I mean by that is, what are the aims of the couple in terms of how frequently they like to be sexually active, and what they realistically expect from their treatment, because that helps guide me in terms of what to advise the patient about their options. So in terms of a practical evaluation of patients, periodically we will do some investigations beyond examining the patient and routine blood tests. I may do an ultrasound if I'm suspicious that the patient has an issue such as Peyronie's disease, which is a fibrous scarring of the penis. We may do what's called a duplex study, and this image on your screen shows an injection being delivered into a model of a penis, and basically an ultrasound is undertaken to look at the vascularity of the penis, look at how quickly the blood flows in, and then how quickly the blood flows out. There's also what's called a nocturnal penile tumescence test. That's basically a sleep study for erections. That's uncommonly needed. Once the patient has been assessed and I have a reasonable understanding of the patient's erectile function and also their aims, desires, the couple's motivation, I do try and provide a goal-orientated management strategy. And that, when I say goal-orientated, not my goals, but the patient's goals, aiming to provide an appropriate erectile response for the patient in the setting and in a way that they deem to be satisfactory, or as satisfactory as we can achieve. And that could be non-pharmacological options such as seeing a sexual therapist or counselling if I do feel that there's a significant psychological component to the patient's erectile dysfunction. Then there are medications or pharmacological strategies, and I'll talk a bit more about these in the near future, just later on in this talk. So there's PDE5 inhibitors such as Viagra, and Cialis, and Levitra, and now Spedra. And also intracavernosal agents would be considered pharmacological, such as Caverject or multiple agent therapies which are available. And then we look at minimally invasive or non-invasive physical ways, such as the vacuum erection device, and also in the armamentarium, certainly not last, or certainly not least, is a penile prosthesis. So the aims of counselling are to obviously exclude depression, look at lifestyle modification, such as alcohol, diet, tobacco, weight, and exercise improvement, and cardiovascular improvement. We may give a therapeutic trial of oral agents if there is a psychogenic component to impotence. And what I mean by that is some patients lose confidence in their erectile function, and so as a way of overcoming that or improving their confidence, we will put them onto an oral agent such as Cialis, which is known as tadalafil, to try and improve the patient's response to stimulation and give them more confidence. And often in patients who have a degree of erectile dysfunction related to psychogenic impotence, then a trial of medication with appropriate counselling and reassurance, and then weaning them off the medication once their confidence is back, will often be satisfactory, and obviously a referral to an appropriate counsellor. So as you know, oral therapies came about in the mid to late 90s. This is really an old cartoon, but it's really quite typical of the approach that was achieved by men and by the drug company Pfizer, who developed sildenafil, and sildenafil is Viagra. And these are what we call PDE5 inhibitors. There are 4 available in Australia: sildenafil or Viagra, vardenafil, which is Levitra, tadalafil, which is Cialis, and avanafil, which is a newer agent called Spedra. They all work in a very similar way. They essentially improve the blood flow in the penis and maintain blood flow for longer. And the way that works is they promote the smooth muscle relaxation in the blood vessels in the penis, and that ideally results in an improved erectile response. And certainly with men who have mild or mild to moderate impotence or erectile dysfunction, then these agents have a very, very good place, and they are highly effective. They obviously are simple to use, and in most settings they can be utilised with some degree of convenience, especially some of the agents which can be taken daily, for example. They are medications which can have side effects such as a headache, facial flushing, worsening of any pre-existing reflux, nasal congestion, sometimes visual disturbance. In particular with tadalafil or Cialis, there can be a described backache, and they do have a specific contraindication to nitrate medication. And nitrate medications are medications which are used to treat pre-existing heart disease and dilate the blood vessels to the heart. They interact with these agents, and they can produce quite problematic or refractory low blood pressure. And that's why in patients who take nitrate medication, we won't use these agents. The other form of nitrate therapy is with hemorrhoidal cream. Some hemorrhoidal creams do have nitrates, and so that's something that needs to also be kept in mind. Moving on from oral therapy, the next step, so to speak, in the armamentarium is using injection therapy. That's intrapenile injection therapy. And essentially the major drug that's available for this is alprostadil, which has a pharmacological brand name of Cavaject in Australia. Alprostadil is a natural prostaglandin, so it's actually present already, and this is just giving an additional dose of this prostaglandin into the penis, and by doing that, essentially it results in an improvement in blood flow into the penis. These drugs have been around, or this drug has been around for many, many decades, quite effective. In some patients, they'll also be given what's called bimix or trimix or quadrimix. These are mixtures of agents, but generally they will include a proportion of that alprostadil to provide an improved result. So the complications which can occur with injections are some patients can develop what we call a prolonged erection or a priapism. A priapism is an erection which goes on for longer than 4 hours. And that is somewhat of a medical emergency. It's not common, and generally those of us who initiate men on injections, we will get them to titrate the dose up, so we won't start at the maximum dose. We'll work up to an effective dose using experience and our understanding of the degree of erectile dysfunction the patients have to start an appropriate dose. A proportion of patients will have pain from the drug, not just from the injection. And if that's the case, that may be an indication to move to some of these other agents, such as Bimix. There's a small risk of penile scarring. That's something we want men to continue to monitor to make sure they do not develop that. And if you look at 10 men, for example, who start penile injection therapy, about half of them will continue for a period of time and half of them won't. The reason they'll stop is because of pain, they don't like injecting, or they don't find it effective. In terms of the minimally invasive strategies that are available to us, this device, a vacuum erection device, is certainly an option. Vacuum erection devices, as you can see from the image, are basically three components. There is a cylinder which fits over the penis, a pump, and a constriction band. And essentially it uses negative pressure to draw venous blood into the penis, and then a constriction band is placed around the base of the penis to prevent loss of that blood. It doesn't result in an increase in arterial blood flow, it's venous blood. And again, the effectiveness of this really relates to, as stated down at the bottom line, the success is dependent on the enthusiasm of the instructor and the education that's provided and the enthusiasm of the couple. Some problems that can arise, that the penis with time, because it's blood that's held in the penis, and it's venous blood, can become bluer. It's not causing danger unless it's left on for an extended period. The penis can become cold because it's a peripheral structure and there's no blood flowing through. There can be some pivoting at the ring, at the base of the penis. You should limit this to probably 30 minutes or less. It does require good dexterity. There can on occasion be some bruising, and also with orgasm there can be some impact on ejaculation, and that's probably can be overcome by specific rings which do have a defect on the underside where the urethra comes through, so that allows ejaculation, but that can be an issue. So I'd just like to talk now to you, or with you, about prosthetics. And prosthetics, for many facets of medical care, have been around for a long time. And in relation to prosthetics, we do have a penile prosthesis as an option for the restoration of erections. And these images that you can see on your screen, the image on your left is the penile, the three-piece penile prosthesis, and on the right, it's basically how it's positioned in a patient. And the three pieces relate to the reservoir on the top of the image on your left, the cylinders, of which there are two, which go into the penis, and these are partially or moderately full. And then there's a pump and a deflation button, which is one component in this model. The image on your right shows the reservoir sitting up beside the bladder, the cylinders in the penis, and the pump sitting in the scrotum. These are hydraulic devices. They are saline filled and they are implantable. And these devices have been utilised now for about 45 years. The technology has obviously been improving over time, but essentially they are very tried and true and have been around for many decades as well. It is a surgical procedure, and you can see the setup here for the procedure with the nursing staff here, the operative tray, and there are obviously more instruments in this, and then it's a sterile procedure, highly technical. This is a patient through an opening in the scrotum through which the procedure is done. You can see that the penis is laid out, the patient is draped, there's a catheter in the bladder through the urethra, and through this incision the whole device can be placed. So it's not put in generally to the lower tummy, and it's on an incision on the underside of the penis on the top part of the scrotum at the front. So penile prostheses are used to treat moderate to severe erectile dysfunction, and generally they are utilised in patients who have trialled oral therapy or injection therapy and don't like it, or that has failed. They're generally in younger or more active couples, often post-prostatectomy or with other medical issues such as diabetes, etc. It's not an age-related factor as to who, or a qualifier as to who gets this. It's really more a case of who it's most appropriate for. The patients must be well enough to have an anaesthetic, obviously well enough to undertake sexual activity, have good hand function so they can pump the device up and let it down, although that doesn't preclude a patient. Some patients may have Parkinson's and have reduced hand function, and their wife or partner may completely appropriately be able to inflate and deflate the device for sexual activity to allow the couple to undertake that. It is generally an overnight stay procedure, and it's mostly about a 2-week recovery after the operation. Interestingly enough, if you look at the literature on penile prosthesis implantation, there's a very high satisfaction rating. It closely resembles a natural erection, and the cylinders that are placed into the penis do grow in length and girth or width. They're very reliable, it's convenient, you don't have to take anything with you if you're traveling, unlike injections or tablets. When you want to be sexually active, you can just reach down, pump it up, and you can undertake sexual activity. It is also discreet. If someone is standing there with the device in weeks after it's been placed, no one would know. The important points to really highlight are there is a period of convalescence after this. It is an operation which requires a patient to take some time off from routine day-to-day activities, especially in the first week. No heavy lifting for a month. It is obviously necessitates a little bit of post-operative analgesia for some pain. There is a very low infect risk, generally of about 1 in 200, and about 20% of patients have the device revised at about 10 years. And that's because most of the devices will last 8 to 10 years. A proportion of the patients then have the device fail, whereby the fluid leaks and they can have it replaced. And it can be replaced any time that happens. You don't need to wait. So in summary, I'd just like to highlight that erectile dysfunction is a relatively common problem in Australia, suffered by many Australian men. There is an age-associated increase. Erectile dysfunction in most men can be evaluated by their general practitioner. Most patients will respond to simple medical therapy, but if they do not, then they should be referred to a urologist if they wish to pursue that further. Penile prosthesis is an effective option for treating erectile dysfunction should the patient find that injections or other forms of therapy are ineffective. And the penile prosthesis is suitable for those patients who find that injections are either not working or they're unwilling to try them. But patients don't need to automatically move from tablets to injections to a prosthesis. They can go from oral medication straight to a prosthesis if that's their preference. So I'd just like to close the talk at that point. And I head back to Christopher.
Thanks, Greg. That was a really great overview of erectile dysfunction and management of today. I've had a couple of questions coming through. I'll just looking around to those. So we hear a lot about the treatment for erectile dysfunction and prostate cancer associated to more surgical treatment of prostate cancer. Are these methods you just talked about now, the medications pumps through to the additional procedures, are they some form of management for men that are undergoing radiation therapy as well?
Yeah, absolutely. As sadly enough, we know patients who have radiation therapy, although there are a couple of forms of radiation therapy, obviously low dose radiotherapy, high dose external beam radiation therapy, patients who have these sorts of treatment can absolutely move through these treatment options. And a number of my patients may have had radiation therapy. We obviously know that radiation therapy doesn't affect the erectile function immediately, but it does accelerate the natural decline. So that's important thing that many need to be aware of. They can absolutely undertake these treatments.
So I guess that leads to another question here that someone's got about they've been managing their ED with injections and pumps and things over a number of years. Is there now any added benefit for them trying something like medication with the PD5 into the mix if they haven't tried it already?
Look, if they've not tried it already, that's reasonable for them to undertake a clinical trial of a PDE5 inhibitor, Viagra, etc., obviously, as long as they don't have any precluding factors such as taking a nitrate or they have a significant cardiac history, you wouldn't want them to try it without clearing that with a cardiologist. But if they've not tried those things, then it's very reasonable to trial them with those providers.
for someone in the short term, so let's say 4 or 6 weeks after surgery, now talking about a surgical patient, completely dry, so they're continent present, but have had no erection since surgery. So number one, is this normal? And number two, is there use for GP in this setting? And if so, if the GP seems like it's a long story, if the GP is also refusing to write a script for the particular medication for them, is there another step that they can take? So A, is it normal? B, should they see a GP? And how do they make the GP follow through, I guess, the advice that you give in
That's a good question. I suppose just to reassure that man who has written in, it is probably more common than not that at 6 weeks, it's great that he's continent from a quality of life point of view, that's fantastic, and hopefully that patient's cancer control is excellent as well. Thirdly, then, if yes, what we would generally trial in most men who have no contraindications is tadalafil at 5 milligrams daily, and we'll get them starting that as soon as their catheter comes out or shortly afterwards. And your GP, as long as your GP is comfortable, should be able to write a script for tadalafil. If that's not the case, I would anticipate that clearly you've had an operation, you have your urologist. I would ask your urologist at the post-operative review to, if they're happy to start you on that medication. But so not uncommon at 6 weeks, doesn't preclude recovery of erections, and yes, I would start something at that time.
So somebody's talking about the support on the other side of men going through erectile dysfunction and talking about that MDT support. So someone's talking about how they've had interactions with specialist nurses during their survivorship following treatment, and what kind of support do you believe should be available to these men that are undergoing, I guess, within the survivorship phases? What members of the healthcare team are obviously beneficial to them?
I think in a modern urological practice, it's just critical, and it should be just part of what is done. In my practice, we have 2 nursing staff, one of those a clinical nurse practitioner, and they absolutely get involved from prior to and then after treatment. They are very involved in terms of any queries regarding convalescence after surgery, and then also in initiating erectile restoration therapy. So our nursing staff will consult with the patients, initiate them on whatever form of treatment they wish, vacuum device, injection therapy, as well as oral therapy with PDE5 inhibitors, and I'll follow them through as we do as part of the post-operative care. So I think it should be considered, relatively speaking, the standard of care moving forward.
Perfect. Okay, so just last question. We've got someone who's kind of gone through that whole array of treatment options you've explained here today, and they're looking at a penile prosthesis. So I guess you've answered this question by the first slide, but what support or information is available to someone who is looking at having a prosthesis?
So I think probably one of that website, penileprosthesis.com.au, is a good option, or you can just do a general web search. It is always good, in my mind, if a patient wishes to speak to another man who may have a prosthesis in place and is happy to speak to other potential patients regarding their experience. And because obviously, from my point of view, as yet, I don't have a penile prosthesis, but if I was a patient, the patient's journey is very personal, and that would be a very useful strategy. And we have patients who are comfortable doing that in my clinic. So I would say that that's a very useful part of it, but going to that website would be useful as well.
Perfect. All right, I'd like to thank you very much for today, Greg. You've been very informative. I'm sure everyone's got something out of today's presentation and some of those onward referral points there as well, which is really great. So
thanks for the opportunity. That's brilliant.
Not a problem. Thank you very much for joining us today, especially around such a hot topic. So we've had the largest number of registrations we've had for one of these events, which is really great. So
That's amazing.
yeah, live broadcasting on YouTube as well as on the webinar platform. So that's really good. So thank you very much for today, Greg, and everyone. Thank you for joining in today, and we'll look forward to bringing you another educational topic in the next couple of months. Thank you very much.
Thanks to everyone. Bye-bye.